full spectrum hospital. He has wide experience and he is very contextual for the topic. He has been in practice, he has taken the academic experience, he has been faculty in various colleges and he has also done his super specialty. So he is one of the key panelists for this session. Dr. S. Manazir Ali, he is very experienced, former professor, Aligarh Muslim University. And Dr. Seema Rai, she is professor in Government Medical College, Faridkot. So beyond residency, start practice or doing super specialty course. In our days, we were not sure what to do. So actually that was not pre-decided, but the situation is rather different now. Most of the residents, they have their plans in mind for their future endeavor. So basically when we talk about the healthcare, there are three basic stakeholders: government, doctors and the public. From the government lens, we see what is the situation. So 2/3 of our population is residing in the rural area, and in those rural area hardly 1/3 of the doctors, they are giving their services. So there is a huge discrepancy. So government has taken proactive action in this, and government has increased the seats in MBBS, MD as well as super specialty. So you can see in the last 15 years, MBBS seat has increased almost 300%, MD seat has increased almost 350%, and super specialty seats has increased almost 270. So just have a look what are the pros of super specialty training. So it gives you opportunity for advanced learning, skills as well as teaching, adding your teaching profile, efficiency transforming into better clinical output. So this we all are aware of. Let's have what are the cons. So it is a tedious process for the patient, especially, and costly affair for them, and somehow it is creating some complexity, and the strained doctor-patient relationship is there due to this. So where we are during residency or after early residency, there is a dilemma where to go, whether go to early practice or do the super specialty course. So through our eminent experience, experts, analytical thinking, we'll try to sort this dilemma through these perspectives. What is the changing landscape of pediatric practice? What are the career path options? What are the different practical and economic consideration? Personal growth, work-life balance, that is the best thing for our resident, future and policy perspective. So thanks to Dr. Seema Rai for doing a short survey in very short time. So we did this survey on the residents who are pursuing their MD or MS, and we have certain interesting observation. So you can see the most of the resident, almost 66%, they are inclined for the DM courses or fellowship courses, and only 10% they have their mindset for going for the early practice. So you can see the situation here. So with this background, I request senior panelist Dr. S. Manazir Ali. How has the landscape of pediatric practice changed in the last decade? Has it become easier or harder to start independent practice right after MD or DNB?
After the graduation, post-graduation and what they are doing, usually they are shifting to the super specialty and they have shown the process. But what we are going to be, the basically problem is that we have never teach them how to establish their clinics and how to go through it after when you are doing the practice. So it's a very, very important thing. If you see why this is happening, there is a lot of changes happening. And this is the shift of the disease pattern that will change. Drastically, usually it was not that. Neonatal and perinatal advances are good. So we have to be cope with the other they should keep on doing. And what happened in India? Technology transformations are going on. So the person is doing the private practice should also happen well aware of the what actually the technological transformations and what are the equipment, what the things to be used. Professional ambitions, what we like to do, what we like want to earn, what we like to achieve, what we like to do in other areas. Then higher competitions are there. Some are doing brilliant activity, some are doing so there is a different way that can happen. Demanding patients. The demand of the patient, they want to get the super special patient, rather to do it. So it's very, very important. Trust me. Family centered and right-based care, very important. They should be there. Global health and policy, which is also very important. So there is a drastic change in that. And increase number of legal complications. That there. So these are the facts and what they.
Thank you, sir, for highlighting the point. I think sir has rightly mentioned that there is no doubt, or in a nutshell, the private practice has changed a lot and it has become little harder than the previous days. So all the residents sitting here, if they have any question, they may give the written question to Dr. Nikhil. Dr. Nikhil, raise your hand. Raise your hand. So and if you have any question to be asked with our eminent panelists, you just hand over the written question to Dr. Nikhil. So do today's residents feel more pressure to sub-specialize than previous generation did? If yes, what are the reasons of factor? Dr. Seema, please enlighten with this question.
Gratitude to organizing team for giving me this wonderful opportunity and adjusting the slot. Thank you so much, Dr. Ajibor sir. Now coming back to the question, yes, I strongly feel that the pressure has been not felt for the today's generation, but for the last 1 decade, the pressure has been felt already by our generation as well. Why? Because after clearing MG, the bar has been set like as premier institute or state. There used to be huge difference. The institute were conducting already pediatric cardio, ICU, NICU, nephro, so many much more subspecialties have come up. So now the residents feel yes, from the plain MBBS to simple MD, now what next? Simple MD is not sufficient for me, I should do something more. So to enhance the career opportunity, advancement of the clinical skill, more in-depth knowledge in the research, and yes, definitely in conferences, if we say yes, I'm GM, it gives extra edge and prestige. And financial growth, I would say definitely a big yes. You go to the international, national surveys, the difference in the pay, the MD versus DM, super or subspecialty is a huge difference. So it's a huge yes. Today's generation is definitely moving towards the subspecialization or super specialization.
Thank you, ma'am. Dr. Vijay, what are the most common factors that influence a pediatric resident's decision to either start practice or pursue a super specialty?
Thank you, Ravi sir. Thank you, organizing team, for providing us the opportunity. Starting with this is a very important question which comes to every resident mind, and the factors which we have felt and most of the people feel is the mentorship or the guide or the teachers. So sometimes when we are resident, they are the role models for us. Sometimes our friends, our seniors, our peer groups, or some role models in the private practice, which we see them and we grip. So once they become our role models, we want to imitate like them, and we try to be either practice like them, or we want to become academicians or super specialists like them. So this is the most common thing. How is your exposure in the present department? Another thing is how your institute is well equipped, because in India there is a difference in the capability or the training centers of the institute. For example, if you see the training in the south, they are different. Training in the Delhi north, they are different. Training at tier 2 cities are different, and training from tier C cities are different. So we cannot compare the MDs passing from all 3 cities are same. So it is very difficult to say that all MDs are same, all MDs are equipped all. For example, when we were doing training, we need to learn more. For example, if somebody is training from some good institute like AIMS or some super specialty institute, so they were already trained in that aspect, so they can jump directly on the practice because that need a skill. So all these things come into the account when you plan either for super specialty, either for a practice. Thank you.
Thank you, Dr. Vijay, and definitely there are more options in the super specialty fellowship and observership in present era. So this is the another interesting response from the participant who did the survey. So if those residents who are going to be practice, so what type of practice they want to be involved? You can see that most of the residents who want to practice, they are inclined for the individual practice or office practice. I think this is one of the reasons for their family life balance is one of the reasons behind this. And you can see very few patients, very few participants, they want to go for run their indoor hospital. What are the key advantages and disadvantages of starting independent practice immediately after residency? This immediately after residency is the mandatory period of residency, which is almost 1 year due to their bond condition or otherwise. So I request Professor Dr. S. Manager Ali to tell about this.
Thank you very much. So what actually happens when they are wanted in the starting independently? If you see when they are coming to the market, disadvantages may be that early and they become immediately dependent. Then early professional segment is there, that is very important, they depend on the family and more professional experience are there. They keep that. And this, but the disadvantage is lack of confidence. If they compare with others, they think probably I got some stability in terms of infrastructure, in terms of academic equipment, and in terms of even the manpower. This will be important. And competition with the super specialty. They have to compare whether they are in and part, and trust from the patient also. And lesser academic experience. So when they come with it, they will have time. That's why it's very, very important that we have a collaboration with their partner, metropolitan and the private partnership, so that they can keep on their knowledge.
Thank you, sir. I remember the scenario 2 to 3 decades ago, when as soon as the MD exam is over, MD result is out, people they start buying their big instruments and their clinical tools required for the practice, and they start practicing. Now this is not the situation. The scenario has changed a little bit. Dr. Vijay, for those who choose super specialization, what motivates?
There are two parts of this questions, like what was the motivation for super specialization. So this is the overlap of the previous question, like what our role models are in the private practice, what our role models are in academics. So we see them, we read and grow seeing them, and we want to become like them. Our peer groups are there, colleagues are there, faculty are there. When we were doing MD, like we used to see our DM candidates, like Dr. Bhargav sir was there, so he was DM and so we always used to think, okay, we can read much more. So these people somehow become good role models. Dr. Shinvekar sir was there, so he was a brilliant academician. So when such a good academician is there, all students try to become like them. So these are the factors which helps that we can do better in the present department. Another thing, the second part of the question is what is career satisfaction and financial stability? See, this career satisfaction and financial stability is a very tricky question. I don't know at what level you become satisfied and what level you become stable. Because as a general consensus, more you read, more you grow, you become satisfied, more you earn, you become satisfied. But that is not the rule. Sometimes this is the other way around. जैसे कहते हैं ना कि आधा मटका ज़्यादा बचता है, खाली मटका और भरा मटका कम बचता है. So this is a sole dependent upon the individual that you have to create a realistic satisfaction, realistic targets in the academics and realistic targets in the finances. So I don't say you don't go for reading or you don't earn, but you have to be realistic depending upon your capability, your skills, your family, your social surrounding, and then you go for it. Don't chase anybody else. You become yourself and follow your own path. That is the best way to be satisfied and financially stable.
So don't put your feet in another's shoe. That is the expert opinion. And what is the participant response? Let's see. Very interesting. So the question was why we need to do super specialty. So most of the respondents, they found that inclination for academic and research. They have inclined for academic and research almost 50%. Then broad specialty practice is tough due to increasing competition, as already Dr. Manazir Ali sir highlighted. So these are the more pressure. Yes, peer pressure is also there. If somebody is doing BM or somebody is doing fellowship, why should not I? And those who are choosing super specialty, you have seen that already most of the respondents, they want to do super specialty, but at the same time they find that super specialty practice is challenging. You can see more than 80% they think that super specialty is challenging. And what are the leading challenges? You can see the lesser number of patients, restricted patient load in super specialty. Somehow your field is restricted by the super specialty, and high cost of setting clinic and hospital establishment after doing the super specialty. So these are very interesting observations from the respondent. Vijay, continue with you that is there an ideal time in one's career to pursue super specialization, or should it be done right away after residency, and how long one should try for super specialty?
I think the earlier you do, better it is, because see, super specialty training, as you know, it's a mentally challenging, physically challenging, and socially challenging. It's not a easy going course. Sometimes 2 years and 3 years. It takes a huge toll on everything, and you have to sacrifice many things when you are doing some trainings. So when you are more flexible, when you cope with the things. I have seen people doing later on also and doing very successfully, but my advice is to complete it as much as possible, as soon as possible, so that you can make your realistic target soon in your life, and you can make a settled decision earlier. Thank you.
We have seen these people, they are doing LLB, LLM at the age of 60 or 70, but hardly we find any doctors doing super specialty at that particular age. Thank you, Dr. Vijay. Dr. Seema, how do mentorship and institutional culture influence the decision between clinical practice and further specialization?
Yeah, we will start with the little word mentor, which was earlier used by our chairperson in her slide as well. The term mentor is derived responsibility of his son to the person named mentor, and the mentoring actually point from that culture as per Ramani 2006. Most of the doctors, they quote that whatever they have achieved in their lives, financially, professionally, academically, it is because they were under the guidance of a excellent mentor. That mentor needs not to be very senior, super senior kind of person. Even we are taking this mentoring program in our CPME. In the foundation classes last month, I took the lecture on mentoring and mentorship. So right from there, and we teach the students that they can make their mentoring final students. Whosoever is senior to them can guide and become the mentor. Mentor-mentee relationships are excellent, and usually who can become a mentor-mentee has been explained excellently by ma'am. So I will not further take the audience through that, but it definitely has an impact, huge impact on personal growth, career trajectory, handling stress, because MBBS, MD, fellows, DM, writing paper, getting it published, we need mentors, teachers all throughout life. It is not up to the completion of one degree and that is over. No, mentor-mentee relationship, good relationships actually we carry still our last breath. So who is a good mentor? Which we think that I can easily approach. There is no difficultly or इतना कोई horrible या not horrible, very scared. You used to be scared to approach our HOD to even ask a simple question. That kind of barrier should not be there. So my mentor takes everything very casual and make my life easy. And my mentor solved absolutely all my problem. This is an ideal mentor. So definitely this is a big yes. Mentorship program or the institution should think that even for the PG teaching, the mentor should become a part in the NMC criteria as well. Thank you for putting this question.
So a good mentor can be role model as well and influence the mentee or resident life. So how do financial realities such as student loans, setup costs and earning potential affect the decision between private practice and super specialization? So finances is everywhere, so it is also here a crucial factor. Dr. Manaj sir.
Very, very important that the financial part is when you are starting a practice. You see that finance is equally important for an early practice and doing supervision. So if you do a supervision and all, then you know what you do. But early this happened to me in practice, it will be very things will be required for infrastructure, for equipment, for a manpower. Early practice, that's very important. The cost establishment and hospital. This is very, very important. And as you know, if we are starting at this individually, you have to take this waste management, clearance, pollution management, fire. These are the three most important. And then other than occupancy and all, it's very, very important. Family backup is also important. How the family is taking care of financial. Early earning to support the family. Depends upon the family, what the situation. So this workload and lifestyle, that's very, very important. Doing a super specialization and also dissertation. Super specialty course fee and expenditure is huge. And most of the time they have taken, if you get a super specialty, they have got a long term. And they have to work in a place that is a 1 year or another. And you know the super specialty they are. So they don't like to overload. This is very, very important. The stipend constraint is very important that you get from the south is very, very less as compared to the north. So the stipend is very, very important. And cost establishment superspecialty really has and there is a multi-prong, so a lot of people this apart from that the motivation is very, very important. And I give you one example of it. I will not name the name of one of the medical colleges. There was a very educated person, they came to the exams, they are giving exams. They say, who is this now? They told me, this fellow was a fourth grade learning. He was about to go to bank. And he was so much motivated because there is no age limit for it. So much motivated that he did this MBBS and then he was very good. So even the motivation is very, very important until others. These are all the things that we do.
Thank you, sir. I remember yesterday in oration, Dr. Thangu Velu sir said, remove L from the urn. His mentor explained it. So Dr. Thangu Velu sir was in requirement of early practice or early earning. So his mentor told him, for now you remove L from the learn, do earn, come back, then again learn, then again add the L to your earn. So I think this could be another option. So how do job opportunities, if in practice serving number of patients, differ between general pediatrician and subspecialty in India? So both scenario, if job opportunities and number of patients in practice. So Dr. Vijay, please highlight.
For having a DM or MCH training, so definitely job opportunities will be quite higher as compared to the MD and DNB, because anybody seeing your CV or portfolio that will add to your marks, and they will definitely want to have a trained person, especially in government setups, even in corporate setups. So in corporate setup, they will see the skills also, that how many skills you have, how many courses you have how many trainings you are being, so that you can perform on their patients. So definitely job opportunities are more. In practice, number of seeing the patients. For example, if you take an example of my super specialty and neonatology. If you see OPD patients, definitely there are no more OPD patients in neonatology. Mostly they are ICU patients. So definitely the number of patients will come down, especially also in the like pediatric surgery when you see there are less OPD patients as compared to the surgical patients or admitted patients. When you compare the broad specialty, they have more patients because they can cater to the many patients. But I still feel this is a super specialist becomes only after completing the MD training. So it doesn't mean that you have forgotten your basic training. So it depends upon what you want to practice, and if you have extra skill, that should not hamper you. You have to decide what you want to see. For example, if I'm learning one thing every day, that doesn't mean what I've learned in the past I will forget. So this is one extra skill in your quiver. So why you are hesitate and make things that you will have tubular vision? So I think it is a matter of practice, it is a matter of thinking, and it is a matter of adding one more skill. For example, in the present example, there are one famous MCH surgeon in Gwalior, everybody must be knowing, that he is doing pediatric surgery also and general surgery also. So that doesn't count that you would come down on the practice. So yes, in government setup, the people channelize themselves, curb themselves. But if you want to do, it depends on your choice, and the government will never say no to it. Thank you.
So very important message, even after specialty, don't forget the common things, don't forget the basic skills. And you can continue and you can add on your patient by doing the broad specialty along with super specialty. So what role of geographic factors like metros versus tier 2 city, tier 3 city more viable? Dr. Seema, I request you to answer this.
Thank you, sir, for the wonderful question. Yes, geography plays a very important role in deciding where I want to live peacefully or I want to earn in millions and we might need 2 or 3 sleeping pills at night. So definitely there I have made this tabular form that if you see that academic, research, finances, this all will be more in the metros or tier 2 cities as compared to tier 3. So academic, clinical exposure, all the seniors, they used to get settled in Delhi, Kolkata, Bombay. First hospital in India was established in Bombay as well. So if you want to get learned, you have to move to, you can say, topmost city, and then you decide eventually how much you want, whether you're first generation doctor, second, third, you want to earn money or you want to make so much money that your future generation do not need to work hard. That is a tough decision you should make at the right time. Lifestyle, yeah, I'm like I'm very fond of watching movies. If I shift to a village, I will not be able to move, see a movie once a week. I need to plan that, oh, I will visit a city and then plan. So yeah, if you are planning to settle down what kind of quality of life you want, you definitely need to look at where you want like to live. Definitely kids also will be reared in the good school. The schooling also will heavily influence where you are planning to settle down in life. Socially, family proximity, interaction, like in villages you hardly say kitty group, but in cities like tier 2 cities also 2-3 kitty groups are there, clubs are there. So you have a very nice work-life balance. As far as the tier cities, I'm not saying that people who are living in villages, they don't enjoy, yeah, that kind of thing they are doing will entirely be different from what you can say doctors usually tend to do. Policy heavily influences the decision. Like these days, bonds have come out for the past 10 years that even after doing MD, you have to stay in the rural job for 1 year. These bond influence the, you can say, doctor's choices, but I have seen, I'm sure that many of you have observed that majority initially never used to fulfill or pay the fees and used to leave. So these all are the factors which helps to decide us where you want to live. And you should live peacefully at the end of the day.
Thank you, ma'am. Rightly said. So when you are going to practice, I think you should have in mind after 1 year, after 5 years, where you see yourself. especially the setup, especially the city where you want to work. Do current pediatric residency program adequately prepare trainees for independent clinical practice? I request Dr. Manazir Ali sir to enlighten us with this question.
First of all, I tell you, no test technical design. Majority of them have got. They only so no part of the 4 months curriculum that is related to clear. The part where they are establishing any other than practical curriculum, no curriculum. Neither better tests are, neither the guidelines are available, but they are very very. Practice of troubleshooting, skill writing, skill writing. So the skill is writing, and they are actually they say that the moment you have 3 years, 1 year or something to live this, you are not reading and not you are practicing to something. So regular skill and review will be very important, and one should do it. Third is depends on the mentor and subject to what type of mentor. Mentor play very important. Usually they copy resident and all, they copy the mentor. The mentors are very aggressive and the behavior is also very important. Similarly as a child, they copy and their parents. What their behavior I can with their parents, their father and mother, they already detect. Another thing, the inclination and has an experience that is important of the mentor. And the students play, in this mentor play, for each mentor, whatever the mentor that has to be variable mind setup, whether they want to go to the meeting, whether they want to go to the academy. Now there is a practice happening that they are carrying the civil services. A lot of the students, they are now after MBBS, so much value confidence, they go to the field. And they are happy what they want to get, rather to be in the practice. So this is their mindset. They are there. Mindset is the community medicine, if they are having, they think they go to the issue once in the WHO or so that they will do it. But you know, this is what happened to them, even the WHO and they are going to be transparent. Another is the limited exposure to the summer station, when they are not working. So they are not exposed to them, they are so there is an unlearning that will happen, decay of the skills, decay of the knowledge of children. So they need
Thank you, sir. So, in spite of so many gaps in the current residency program, from the perspective of practice, I think sir very well highlighted the different factors and gaps. Now, let's have a look what our residents think about this. So, the question is, what is your confidence level in starting practice after residency? So, surprisingly, approximately 2/3 of residents they respond by they are reasonably confident and only sometimes they may require the help. And 1/4 of the residents they are quite confident and they think they rarely need any help from seniors. So it is a good, I think it is a good observation. So still we are not at very bad side. So should there be more structured guidance or counseling during residency to help residents make informed career choices? Dr. Seema.
Thank you for the question, sir. This is the next slide, please.
So, yeah.
Thank you. So the structured counseling by definition means a systematic plan approach to provide both career guidance and psychological support to the PG through the regular basis in the confidential session. So it is like more or less like mentor and mentees program, but slightly confidentiality has been maintained in the structured counseling and clinical exposure. There are various benefits and role in the career choices help the student to identify. Like in the MBBS, we have early clinical exposure. So in the PGs as well, if you want to make a like if you want to specialize or private practice or go into the academics, become faculty or professors, we want to like expose them on the regular you can say duties in various wards. If the state medical college does not have their own units, we can have a bridge courses between the premier institute where the premier institute have the subspecialty. So they go and select their own subspecialty, or they don't want to do the subspecialty or go into the practice or become an academician and researcher. Also encourage to make the life a balanced decision. The work-life balance decision comes more if there is a structured counseling or mentor-mentees program, even if started in the PG residency time, and provide more multiple career pathway, clinical, academic research and public health. And it has further benefits as well. The reduced burnout, this is the talk of the town. Every other day we see कि one doctor is either committing suicide or collapsing in the wards while after doing in the wards or after 12-hour long surgery. If we have regular venting out, opening up our can say feelings with someone, sometimes or majority of the times we don't want to talk one-to-one with a family member. If outside the family member someone is listening to us, it becomes a boon to us. एक लाइन याद आती है, अगर दिल खोल लिया होता यारों के साथ तो नहीं खोलना पड़ता औजारों के साथ. So it definitely reduces the stress and burnout, improves satisfaction in the career choices, better academic performance, enhanced professionalism and communication. So these structured counseling session, clinical practice, mentor-mentees definitely encouraged in during PG residency will shape the future of the residents in India. Thank you, sir.
Thank you, ma'am. So is there a mismatch between the number of pediatric super specialty seats? Almost we've seen that 270% increase in the super specialty seats and actual job market or practice needs.
There are far more seats as compared to the actual eligible students. For example, in our college only there were some 12 neonatology seats and hardly we could get neonatologists here. And sometimes if you have some pediatric cardiologist, then there is no seat available. If you have pediatric gastroenterologist, then there is no seat available. So definitely there is a mismatch. But I think corporate, they adjust to this and they can serve better there. So definitely there is a mismatch. But as the people will get aware, the government will formulate policies according to it, and definitely there will be better chances in the future. Thank you.
Thank you, Dr. Vijay. So how can academic institution and professional bodies like ours, Indian Academy of Pediatrics or others, support early career pediatricians who wish to balance both practice and academic interest? This is in the light that those who are not able to go for the super specialty, they started early practice. So how these institution and professional bodies can help their academic interest? Dr. Manaj, sir.
It is very, very important because there is a collaboration to be happened with the academic institution and with the practice. Because what if the new things come to the new academic, they are, so it's important that they should have it. So if regular CA, that could be there, and then you see academic. Because if you are private practice and other things, you not get that time and all. So it's very, very important that they should at least go through this workshop, conference, and not for just going to attend the workshop or not. A skill is very, very important. Right? Whether they are having a mental resuscitation or whether they are having a taking of the drugs and do any other work. So it's important to learn. Academic partnerships is important. Collaboration with the development of academic and clinical SOP should be able to and the guidelines, stick to the guidelines. There is no working time to think that my hair is my hair, so I have to it is not like that. And there's some people have they have got an idea, they go there, they program, they are not everything. So I want to see the there is a no way. Active involvement of the resident is professional activity. Whatever happens to them, they will have a see and they not like that. If they do like this, regular they are not only there is skill and there will be a gap, whatever the gap is, they will be with the institution.
Thank you, sir. So this is the responsibility of early practice pediatrician also, that they should be engaged with academics, they should be engaged with the professional body, and whenever they get a chance, they should add L to earn. Again, after earning, they should start learning. So, respecting the organizers' time limit and coming faculty, I think we should stop here. But very important question to Dr. Vijay is there, that Dr. Vijay, if you could give one piece of advice to current residents uncertain about their next step, what it would be?
I think follow your dreams, work very hard, and then you have the time to decide what you want to do. Make realistic goals, see yourselves and your limitations, your advantages, and then work accordingly. Thank you.
Thank you all the